You have been told it is stress. You've even been told it is anxiety. You have been told your weight is hormonal. You've been told your pain in your hips, your knees, normal. You have been told your inflammation is all in your head. You have brought your symptoms to your primary care doctor, maybe to a cardiologist, and told everything is fine. You may have been referred to an allergist who possibly tested your tryptase levels, and you were told it is normal, it's not a mast cell problem. You walked out of every appointment more lost and with more questions than you had when you walked in. Does this sound familiar? I'm Dr. Stasha-Gae Roberts, nurse practitioner, veteran, BHRT certified, and the founder of Compassion Primary Care. So, this is week 4 of a 4-part series on mast cell activation and histamine receptor patterns in midlife women. It is actually the closing piece. So, over the last 3 weeks, I have walked you through several things, which include the 3 a.m. heart pounding cascade, the fragrance and spicy food reaction, the dermographism welt, the stuck weight that is actually fluid, and the hormonal driver that actually begins at the age of 35. Today, I want to do four things. First, pull the receptor framework together so you have it in one place. Second, tell you why most clinicians have been trained to miss this and how the field is shifting right now in a good way. Third, give you specific language to use with a clinician when you bring this picture to them. And fourth, talk about what changes when you finally find it. So you are not making this up, you are not exaggerating, and you are not anxious. And you do not have to prove you are struggling to be taken seriously here. So let me pull the receptor framework together. Again, as a reminder, there are 4 histamine receptors that matter for what we have been discussing. So, H1 receptors live in your skin, your blood vessels, and also your brain. They can drive symptoms such as itching, flushing, fluid retention, that fragrance headache, and the 4-pound overnight weight swings. The medications that block H1 receptors are very familiar over the counter antihistamines. They include cetirizine, loratadine, and fexofenadine. H2 receptors live in your stomach and your heart, and they drive gastric symptoms, reflux, nausea, and cardiac symptoms of mast cell episodes. Famotidine is the most common H2 blocker, also known as Pepcid. Useful short term. It's not something I like to keep people on long term because of the nutrient absorption trade offs. H3 receptors live in your brain and they amplify sensory and cognitive symptoms. And this is why fragrance overexposure causes that headache, that brain fog that can linger, unfortunately, for several hours. Right now, there are no widely available H3 medications, but the receptor matters for understanding why your brain symptoms are real. Lastly, H4 receptors live on our immune cells, so they recruit more inflammation to areas that are already inflamed, and they are part of why mast cell activations tend to be self reinforcing once it gets going. The H4 inhibitor medications are mostly still in development, and so that is the framework. And this is the reason why a single antihistamine often is not going to fix the whole picture because depending on the receptors is going to drive the different symptoms. So a skin and fluid pattern responds to H1, a gastric pattern may need a short term of H2, and a sensory and cognitive pattern involves H3 receptors. And again, the underlying inflammation that keeps the cycle going involves H4 receptors. So the right combination is individualized and it depends on what your specific symptom picture is being driven by. That is what a real evaluation is going to identify. Now, let me tell you why most clinicians do not recognize this. Most physicians associate mast cell disease with anaphylaxis. That's the bee sting that drops the blood pressure, it's the sudden hives, it's the throat swelling and closing. It is dramatic, right? And so it's life threatening. It's something that has to be recognized and dealt with immediately. But mast cells do not only flood, they can also drip like that annoying faucet. So they release inflammatory mediators chronically at lower levels year after year. And this dripping pattern is what most midlife women with mast cell hyperactivity actually have. And it is the version that most clinicians have never been formally trained to recognize. Now, there are several reasons that compound this gap. The official diagnostic criteria for MCAS requires a measurable spike in tryptase during an active flare. That works great during anaphylaxis. It rarely captures chronic dripping. So, MCAS was the first formally described in the medical literature in 2007. It only received an official diagnostic code in 2016. Most clinicians completed their training before any of this was being taught, and the symptoms are individually unremarkable. Again, women with this chronic phenotype often look healthy. Multi-system complaints in women are routinely attributed to anxiety, stress, and perimenopause. And there is still cultural skepticism in mainstream medicine about whether chronic MCAS actually even exists. The published average diagnostic delay for MCAS is 4 to 5 years at major academic centers. It is actually longer in community settings. So that is not a gap. That is years of someone's life, someone suffering and dealing with this issue, feeling unheard. There is something else that is important to know. The field is actually shifting in a good way. The diagnostic criteria for MCAS that were established when the condition was first formally described required a measurable spike in tryptase during an active flare. That standard worked for dramatic anaphylactic version. It does not capture the chronic dripping version that most midlife women have actually been dealing with. Recent consensus statements and a growing body of clinical research are now recognizing that MCAS in the chronic phenotype is more accurately identified through clinical pattern recognition and a constellation of symptoms across multiple organ systems, not just through tryptase alone. Mast cell hyperactivity that is wrecking your sleep, your weight, your gut, and your skin, and your nervous system is real even when your tryptase looks normal. And that is the framework I work from. If you are told your tryptase is normal, so it cannot be mast cell, the answer is this. Most women with chronic mast cell activation actually have normal baseline tryptase. The chronic phenotype is identified again through clinical patterns and urinary mediators. You can request a urine mediator panel as the next step. If you are told you do not have anaphylaxis, the answer is this. Most chronic mast cell activation in women is not anaphylactic. The chronic multisystem phenotype is increasingly recognized in the literature. If you are told it is just stress, the answer is this. Stress actually activates mast cells through known molecular pathways. Stress is a part of the biology. It is not a substitute for a diagnosis. If you are told you should take antihistamines, the answer is this. I am asking to address the upstream drivers and try mast cell stabilization first. Antihistamines can be added as a second line if needed. If you are told the lab markers all look normal, so this cannot be a mast cell problem, the answer is this. The field is moving towards clinical assessment as the primary diagnostic tool. Recent consensus statements acknowledge that the chronic phenotype is often identified by symptom pattern and treatment response, not by lab markers alone. The right next step is a clinician who knows the current framework. If you are told MCAS does not exist or is overdiagnosed, the answer is this. I am not asking for a diagnosis without evidence. I am asking for the validated mediator testing and for you to listen to my symptoms. If it is negative, I will reconsider. If it is positive, we have answered something really important. And again, I want to emphasize clinical symptoms. That is often the best diagnostic criteria. So go in, be polite, advocate for yourself, write down this information, research it for yourself, and be your own advocate. So, the hardest part of living with undiagnosed mast cell activation is feeling like you are imagining things. You know what is happening even before treatment begins, and this is transformational. The symptoms that felt random suddenly make sense. The patterns you've noticed but could not explain become evidence. Again, that bra strap or belt welt, the 3 a.m. heart pounding, the weight that would not move despite everything that you're doing right, the fragrance headaches, that weird reaction to spicy foods, the decades of IBS that nobody could solve. All of it explained, all of it treatable. When treatment works, the weeks of a successful protocol can be remarkable. Many women describe it as finally being able to live in their own bodies after years of trying to push through them. In integrative care, this is investigated through a combination of symptom mapping, urinary testing for N-methylhistamine, prostaglandin D2, and leukotriene E4 alongside tryptase, and again, clinical pattern recognition. The chronic phenotype is identified through this combination, and again, not just testing alone. Treatment starts with upstream mast cell stabilization, histamine aware eating, and addressing the major drivers. For midlife women, that almost always is a combination of hormonal changes, accumulated stress, and HPA axis dysregulation, gut barrier dysfunction, and some kind of underlying inflammation, which could have been from previous viruses. Where natural stabilization is not enough, targeted antihistamine support is added under clinical guidance. Bioidentical progesterone restoration, when clinically indicated, removes one of the biggest upstream drivers. I am BHRT certified, and progesterone restoration is one of the most useful and impactful tools I use with women dealing with this pattern. Two other clinical tools may be part of an individualized plan. The first is low dose naltrexone or LDN. It is a prescription medication used at a fraction of its original dose. It helps to modulate the immune system and reduce inflammation. It is increasingly used in integrative care for mast cell driven conditions and is one of the tools I consider when clinically appropriate. Amloxanox is an integrative option being studied for inflammation driven by metabolic patterns. Small early phase human trials have shown promising signals. It is not the standard of care, but is the part of the conversation in integrative medicine that may be appropriate in some individualized care plans. And it's being used as a repurposed drug. It's been around for years. So, if you have watched or read anything in this series and recognize yourself, the next step is a real conversation. My signature Finally Answered program is a 3-month root cause investigation built for women who are exhausted, dismissed, and done leaving appointments without answers. Whether mast cell activation is part of your picture is something a thorough evaluation can help to identify. Whether the program is the right next step is something we will figure out together during that discovery call. The discovery call is free, and it is an opportunity for a real conversation with myself and not a sales call. Book your call. The link is in the description. Compassion Primary Care serves women across the entire state of Florida through virtual care with home visits and in person care at the Wellness Center of Ellington for those living in the Tampa Bay and Suncoast region. You do not have to prove you are struggling here. You just have to show up. Book that discovery call. This is not your 20s. This is not your new normal either. And you do not have to live like this for another decade, waiting for someone to take you seriously. I am Dr. Stasha-Gae Roberts. Thank you for trusting me with your time today and taking the time to watch this video. Please share it with other ladies that you know need this. And I look forward to assisting you in nursing your journey to lasting wellness. Bye bye.